Well, good afternoon, everyone. I'm glad that you could join us for our third installment of our 5-part series on the anatomy of a self-funded health plan. Look forward to having you join me today for our conversation. As we've done in the previous two, I'm going to dive in and go through the slides and try to cram as much information as I can into our 30 minutes together, but leave some time at the end for Q&A if there is some. One little kind of caveat or housekeeping item. This particular conversation on pharmacy could be 3 days long, not 30 minutes. And so I'm going to cover a lot, but certainly invite you to reach out and have a follow-up conversation if anything that I mentioned jumps out at you or if you feel like you'd like to know more. So with that, let me pull up our slides here and take you through the anatomy of a self-funded health plan, part 3 of our series, the pharmacy. And just a little preview of coming attractions. In May, on May 29th, we're going to talk about medical management. And then the last part of our 5-part series is going to be talking about stop loss at the end of June. And our agenda today is a kind of 4 components. Number 1, do we think that pharmacy is the most important component of a health plan in preview of coming attractions? Yes, we think that it is. Talk about the role that the PBM plays and what the current landscape looks like. Talk about your PBM contract and what's in your contract, just like they ask, what's in your wallet, what's in your contract, and does your contract align with what your objectives are? And then finally, after I've scared you to pieces, what can you do about it? So let's dive in and talk about the most important component of a health plan. So why am I saying that the pharmacy component of a health plan is the most important component? Well, these 2 graphs that you have on this screen in front of you, these could be any component of healthcare costs. Yes, we know healthcare costs are going up, but what is different about our conversation today is the rate at which the pharmacy component of health plans is increasing and how much we're spending on pharmaceuticals. And I'll show you a couple other components and break this down a little bit further in subsequent slides. But the bottom line is we are spending more and more every year on pharmaceuticals and the prescription drug ecosystem as a whole, and that is not going to slow down anytime soon. And a little preview on this as well is that I believe that pharmacy could be the final straw that breaks the camel's back, meaning if we have a wholesale change in the way healthcare is insured in the United States, either publicly or privately, it's going to be pharmacy that's going to break it. PwC every year does a medical trend forecast. So what do they think that health insurance costs are going to go up over the next 12 months? And unsurprisingly, pharmacy trends are not expected to slow down in 2024. They expect that component of overall healthcare costs is going to be the biggest component and increase at the greatest rate. And the thing that's really eye-opening is the median cost of these new drugs. As new drugs hit the market, they're not coming in at $50 a month. They're coming in at $50,000 or $150,000 or $200,000 a year in prescription drug costs for one new drug. So we're having more and more prescriptions hit the market every year, and the cost of each of those unique drugs when they hit the marketplace is astronomical. And so at some point, this is going to become unsustainable. And just to drive that point home, our friends at Milliman every year release the Milliman Medical Index, where they project what health insurance is going to cost for a family of 4 each year. And they break the cost of health insurance down to 5 components: what we pay for inpatient care, outpatient care, professional services, so paying the doctors, pharmacy, and then all others. And I went back as far as 2015, taking a look at the components and what made up the components of the Milliman Medical Index in 2015 compared to where we are for 2023. And inpatient and outpatient have kind of shifted places in terms of which one's more dominant. But back in 2015, inpatient and outpatient care represented 50% of total plan costs. Today, it's only 46%. Pharmacy, on the other hand, has gone from 16% to 22%, and it's continuing to increase at a higher and higher rate. Professional services actually decreased in terms of what that represents as overall healthcare costs. Inpatient and outpatient as a cumulative total have also decreased. The only one that's gone up is pharmacy, and that trend is not changing, and it's only going to accelerate over the next coming years. Our friends here in the Michigan market, our big commercial insurance carriers, Blue Cross Blue Shield and Priority Health, both had big headlines in the business publications Cranes in the last month and a half. Blue Cross Blue Shield lost over $500 million last year, driven by prescription drug spending, and Priority Health had a similar hit to their bottom line as well. So if you're a fully insured employer utilizing one of these two players, and they're not unique, of course, that's going to drive premiums up. If you have a self-funded plan that's administered the same way as their fully insured plans, of course, pharmacy costs are going to go up. And so it's going to be more and more important to figure out what are tools in your toolbox that you can use to contain these costs. A couple other things on what's coming down the horizon at us, or the pike. Number one, every year, the Food and Drug Administration approves new medications after they go through all the years and years of testing to make sure that they're safe, they're effective. They then go to the FDA to get approved. One of the things that pharmaceutical manufacturers have figured out, though, is that if they focus on a classification of drugs called orphan medications, which are designed or defined as medications that treat 200,000 people in the United States or less, so very rare conditions, they can charge as much as they want. There's zero constraint on how long they can market those drugs and how much they can charge for them. And so they've really started focusing their attention over the last decade on this really small subset of conditions, and 51% of the drugs in 2023 that were approved just fall into that orphan category. Now, these drugs are life-changing or life-saving for those that need them, and I'm not suggesting that they're not important, but the reason that the pharmaceutical manufacturers are focusing their attention here is because they can charge so much more for a drug that's defined as orphan when it's finally approved. In addition to the orphan medications, the things that keep me up at night thinking about health plans is the impact of gene and cell therapy. And gene therapies are often prescription drugs that bottom line, reconfigure the genetic makeup of a particular individual and potentially cure a condition or make a condition much more sustainable and extend the life of an individual with that condition. There are almost 4,000 gene therapies in the pipeline that are going through the various stages of testing and ultimately getting to the FDA. And the FDA approves or anticipates they're going to approve 5 to 10 to 15 of these a year for the next 5 to 10 years. So these are very, very expensive, $750,000 on the low end to $2 million and more on the high end for the cost of these medications. These are coming. And so we need to make sure that we're preparing for that and have strategies to deal with it. So for those of you that are attending this saying, well, don't worry about it, Mike, I've got a PBM. They're going to take care of this for me. The pharmacy benefit manager, they're that middleman that plays the role between the insurance plan and the pharmaceutical manufacturers negotiating the best deals and managing that for us, right? Well, yes and no. Let's talk about the PBM marketplace. There are, as of today, approximately 66 pharmacy benefit managers in the marketplace, and the largest 6 represent 96% of the total market share. So the big 3 are your CVS, your Cigna's Express Scripts, CVS Caremark, Cigna Express Scripts, and United Healthcare's Optum. Then we've got Humana, Prime Therapeutics, and MedImpact, which is the largest independent PBM that's still out there. All others fall into the remaining 4% of the market. And we think that it's really important to know, hey, if I've got the big 3, I'm covered, right? They've got the biggest negotiating power. They're very powerful, going to get me the best deal, right? So I don't need to look at these small, let's call them mom and pop PBMs, right? Well, maybe not. If we take a look at what makes up the family of these large players, they have figured out ways to vertically integrate to make sure that they can touch prescription drugs at every step of the way through the pharmaceutical ecosystem, from the time the drug is manufactured to the point it's delivered to the patient and they consume it. So that's talking about the manufacturers, that's talking about the rebate aggregators, that's talking about the wholesalers, that's talking about the pharmacies, the specialty pharmacies, the mail order pharmacies, on and on and on. And our big 6 players have figured out ways to integrate that and make money every step of the way. And they are very opaque about what that process looks like. And they very often like to feed themselves and make sure that they redirect these dollars back through themselves and their insurance products to their benefit, and oftentimes, from our perspective, to the health plan participants and the plan itself to their detriment. So if it's not going to be the big 6, then what should we consider? Well, first and foremost, I just want to kind of drive this point home because I thought this was pretty eye-opening. We're all very familiar with CVS. I was at one of their pharmacies not that long ago picking up some supplies for my daughter. And so we're familiar with the retail brick and mortar pharmacy of CVS, but they make less money on the brick and mortar than they do on all the pharmacy services, whether it's their specialty pharmacy, their PBM, and all the other opaque places and steps through their particular pharmacy supply chain. So we need to make sure that we are kind of cracking the nut on that and figuring out exactly how they're making money and are they doing everything for us that they said that they would do. So are PBMs a help or a hindrance? Many of you may have seen from me a video we put out a couple months ago and some emails that we sent out about a recent proposed class action lawsuit against Johnson & Johnson by their employees and plan participants in their health plan. They are arguing with this proposed class action lawsuit that Johnson & Johnson did not do their due diligence in managing their PBM. Their PBM allowed their prescription drugs to flow through the plan at much higher costs and in a very self-serving way, redirecting through their own specialty pharmacy, using their own mail order, and to the detriment of the plan participants and the plan. And so one of the things that we know is that, listen, if we're going to use a PBM, which we have to because the current system necessitates that we use one, we want to make sure we're evaluating the various options that are out there and not just looking at the big household names. The reason we need to use a PBM is when we go to a pharmacy and our pharmacists are typing into the computer to make sure that my drug is covered, they're talking to a PBM's computer system. And so we can't go without. We need one, but we need to make sure that we're doing our due diligence and picking the one that is really going to do the best for us. And from our perspective, PBMs fall into two categories: those that want to help us and those that don't. And from my perspective, the big six, I have way too much vested in the current model as it exists today, and they are not ones that really want to help us solve the problem. If we disrupt the way things are operating today, it's going to be to their detriment. These are all publicly traded companies, and so they have to benefit their shareholders more than they have to benefit their customers. And so we think we should look at small, independent, privately held PBMs as an alternative. That said, making a change in PBMs is not an easy thing to do necessarily. It can add complexity to your plan. It can add some confusion to your plan. It might result in you having two ID cards, for example, one for your medical side of the plan and one for the pharmacy. There can be additional administrative costs as a result. But our experience tells us when we're working with an independent PBM that's willing to be part of the solution, we get way more flexibility than we do with the traditional big six players. And that additional flexibility is exactly what we need to be able to manage our plan well and perform well over time and respond to the rate at which this industry is changing. One other thing, if you work with a commercial insurance company who administrates your health plan today, they have a PBM relationship already. And they will, in most cases, allow you to carve out the pharmacy component and work with an independent PBM. But they're going to make it hard for you to do so, and they really don't want you to, because there are dollars that flow through that agreement that benefit the commercial insurance company. And when we carve out the pharmacy, it removes a significant revenue stream for that insurance carrier as well. Not suggesting that's a bad thing necessarily, but you need to be aware of it. And that if you are working with a commercial insurance carrier and you want to have complete control of your pharmacy side, understand there's going to be a little bit of friction in getting that set up. So what's in your contract? Let's talk about the components of a pharmacy contract and some things that you should be looking for. And I'm just going to give you a couple examples. When I mentioned this could be a 3 or 4 day conversation, the contract component could be half of that conversation because there's so much to look into and so much that's easy to overlook that can have a really detrimental impact on your plan. Starting with things that are seemingly innocuous, like definitions of something, like what a brand name drug is or a generic drug, can have a major impact on how your pharmacy component of your plan performs. It's also really important that you have someone review the contract that's familiar with the games that can be played. Very, very smart people who are familiar with reviewing contracts on a daily basis can take a PBM contract, look at it, and think there's nothing detrimental to the plan in there and give it the thumbs up. But if you're familiar with the loopholes and the games that can be played, you can find where they are and make some adjustments and negotiate a better contract. Finally, there are many different PBMs out there, as I've mentioned before, 66 plus. If you are working to negotiate a PBM contract and they are unwilling to play ball or compromise, or they're making it incredibly difficult, know that it doesn't have to be that way. There are PBMs that want to be a team player and are willing to compromise and make sure that the contract works well for both parties. So let's just take a look at a couple examples from different definitions of PBM contracts. So just taking a look at the definition of generic drugs. The first one is generic drugs means all things that are not brand name drugs. If that was looking at that in and of itself, standing by itself, that's like, yeah, it's a pretty straightforward definition. That makes sense. Okay, well, let's take it and leave it at that. But then we can see how other PBMs define it. A generic drug may be any prescription where Metaspan, which is an independent third party, defines it and puts a code of Y that says that Metaspan's looked at these drugs and is considering them Y. So across the board, all drugs with a Y code are going to be considered generic. And it's not the pharmacy benefit manager that's making that determination. It's this independent third party, Metaspan. From our perspective, that's a better definition because we are looking at an independent third party. They're saying what it is, and it either is or is not a generic drug, and it has no other impact, meaning, well, we used to call it a brand and now we call it a generic, and we're doing so for our own benefit. No, Metaspan says that it was brand, and now as of this date, it's a generic, and it is what it is. This last one seems like it goes down that exact same path, but if we look at the last line here, or last couple lines, we're using Metaspan and we're looking at their codes, or we're looking at the basis of a standard brand generic algorithm as defined by the name here is the insurance carrier and the PBM. So again, we're using Metaspan to agree, but the PBM and the insurance carrier in this particular case reserve the right to define it however they want. And so again, we think it's really important to understand what is the definition of it, who gets to define that, and can games be played by saying, yes, it is or it is not a generic or a brand name drug. And there are multiple terms throughout a contract that are like this where games can be played. Another one is rebates. And in 2024, most people are familiar with rebates with regards to prescription drugs. And if you have a self-funded plan, you're probably familiar with the fact that we want to make sure we're getting as much of those rebates back. Rebates are incentives from pharmaceutical manufacturers to place prescription drugs in a favorable place on a formulary. And if you do so and drive utilization of our drugs, the manufacturers are going to give dollars back. That's great. But as we have been more educated consumers and managers of health plans, we've become aware of this. We're pushing the PBMs and saying, listen, those aren't your rebates, they're our rebates, and so we want those. And so the rebate marketplace has changed dramatically. If we take a look at these three definitions of rebate, it's all pretty straightforward. Discounts or incentives received from a pharmaceutical manufacturer. They're all three variations of that. Well, what PBMs and the pharmaceutical manufacturers have figured out is we've started to push back and ask for rebates. They've started taking these fees and calling them something different. If it doesn't have the name rebate tied to it, this definition does not apply, and any of those dollars that have now had their name changed are something that our PBM can retain and keep their hands on. From our perspective, this definition of rebate, which barely fits on the slide, is way, way more favorable. It's not only talking about any and all manufacturer-derived revenue, not just those that are called a rebate, included but not limited to, and on it goes. Many, many different examples of ways that a PBM can make money. And what this particular PBM is saying is that if we get any of these dollars in any of these categories back, we're going to pass it along to our customers. With the prior three, sure, it looks pretty straightforward. We're going to get our rebates back. But if they don't call them rebates anymore, then it doesn't matter. You're not getting the dollars back. So a couple other key points from a contractual standpoint. So why does it matter what the definition of a generic drug or a brand name drug is? Well, if you've looked at your PBM contract, you've probably seen these things where they're guaranteeing these discounts off of something called average wholesale price or maximum allowable cost, depending on if it's a brand name drug or generic. So what they're saying here is just like on the health plan side, we're going to get some sort of discount off of what the average wholesale price is for this drug. And if it's a generic drug, you get X discount, and if it's a brand name drug, you get Y. Well, if they can move the category category that these drugs fall in, it allows them to meet some of these commitments that the PBM is making to you. So they're saying, we're going to guarantee you 20%. And if they can move the drugs around, they can finagle the numbers to make sure they meet those categories. So that's why definitions are so important, is that we don't want any game playing behind the scenes. If it's a brand, it's a brand, and we want to make sure that that's the case. And if it's a generic, it is, and it doesn't fluctuate and move back and forth at their whim. The other thing that I want to point out, why I titled this slide as "Which is Better," is these are 4 different PBM contracts that our partner Granite Peak Analytics helped us compare. And when we're looking at these discounts, we can see, wow, this PBM is offering us a 20% discount on brand name drugs. This one's 18.95, 18.25, and 18.1. And if we look throughout this one on the right, they're consistently lower in almost every category on the discount. So we would say that's probably the 4th worst contract that we could pick. Let's exclude them. Well, here's the difference that doesn't immediately jump out at you when you review a PBM contract. This PBM, number one, is guaranteeing these numbers, meaning if they don't hit them, they're putting 100% of their administrative fees at risk. So they are really setting them lower because they want to make sure that they can hit them, because if they don't, they actually have some skin in the game and could potentially give all administrative fees back. These 3 don't do that. In addition, this PBM sets these discounts as a floor, meaning they're guaranteeing at least 18.1. But if they achieve 20%, 21%, 22%, they're giving you everything, all upside as well. Where all these PBMs, the other 3, they're setting this as the ceiling, meaning if they achieve a 22% average discount, they keep that 2% difference. And so while on paper, it may look like, if we just look at these discounts and these percentages, that this is the worst one, we really need to dive into the contract to understand the components and understand, are these discounts a floor, a ceiling, and what sort of performance components are built into it? What are they actually putting at risk? And this one ultimately is the most favorable when we dive more deeply. Okay, so what can you do? Talked about the fact that we think prescription drugs are going to continue to increase at a rate of speed far greater than any other component of a health plan. More and more drugs are hitting the market on a daily basis, it seems, and the cost of these, not only when they hit the market, are very expensive, but the rate at which they increase in cost each unique drug every year is astronomical. So what can you do to be prepared and make sure that you put yourself in a position to make your health plan as sustainable as possible when it comes to prescription drugs in particular? So we've been using the analogy of playing a game, the game operation in this case, throughout our series, because we truly believe that when we manage a health plan well, it is a game. There's a lot of players in the game, and there are winners and losers. And historically, it seems the plan participants and the employer generally are on the losing end of the table. So what we want to do is we want to make sure we're playing the game as well as we possibly can. And we're talking about players of the game. The pharma industry, I would like to equate to Garry Kasparov, probably the greatest chess player of all time. I thought this picture was pretty appropriate because here he is playing multiple great chess players at the same time, walking around in circles, and he likely is going to win every single one of these games. The pharmaceutical industry is operating the exact same way. They're finding every opportunity to play the game and win at every stop. And we need to make sure that we are aware of the different stops and our opportunities to intervene and at least give ourselves a fighting chance. So what about the government? Are they going to help us solve this problem? You may have seen with the Inflation Reduction Act, there was a component of it that allowed the federal government to start negotiating with pharmaceutical manufacturers for the price that the Medicare is going to pay for prescription drugs. And they just announced the list of the first 10 drugs that they're going to start negotiating between 23 and 24. And these new prices that they're able to accomplish go into effect in 2026. The hope is, number one, this is going to save Medicare money. And number two, it's going to trickle down to the broader market and that other health plans will be able to pay these lower Medicare negotiated rates for prescription drugs. That's great. In addition, the FTC is starting to look into these drug middlemen, the PBM, the big 6 players, because as I talked about, they're vertically integrated and they make money at every turn. This is an example of a terrible PowerPoint slide. I'm not expecting you to read all of them, other than the fact I want you to see, yes, the big 3 that we talked, the big 6 that we talked about are being looked at, and they're looking at them for various reasons, including the fees that they charge, the rebates they get paid, the games that they play with pharmacies, how they steer patients medications to their own pharmacies and away from others in an uncompetitive way. That's one of the reasons that this class action lawsuit has some legs with Johnson & Johnson. And other opaque nature of the whole industry. So the FTC is looking at it, but we need to stay vigilant. It is a game of whack-a-mole. This was for the most recent SEC filing for CVS, one of the big three PBMs, and they're reporting back to their stockholders or shareholders in their quarterly report that they're seeing some pressure with having to share, not only CVS, but the other PBMs having to share with clients a larger portion of rebates, or if we have our contract defined the same way, not just rebates, but other fees and discounts. So we're having to give more of those back, and we're having a harder time playing some of the games we used to play. Well, they're not going to go down without a fight, though. And so, yes, we may have gotten them there, and the FTC may help impact that, but they're not going down easily. First and foremost, the pharma industry was suing the federal government and saying it's unfair that you're going to try to use Medicare to negotiate with us. Fortunately, just 2 months ago, a federal judge threw out that suit and said, nope, can't do it. But the pharmaceutical industry is not giving up without a fight. They're going to keep taking this through the judicial hierarchy, and many expect that it's going to make it to the Supreme Court to see if the federal government can, in fact, negotiate prices. The other thing that we need to keep in mind is this is from opensecrets.org, where we look at how much money any particular industry spends lobbying the federal government. And the pharmaceutical health products industry is number one, $140 billion more than the next highest. If we take a look at our friends in the oil and gas industry, they're amateurs when it comes to lobbying compared to the pharmaceutical and health products industry. So we have an uphill battle against us. And the pharmaceutical industry is really good at playing the game. We're all familiar with GLP-1 drugs now, your Ozempics, your Wegovy's, and so on. These medications originally came out to help folks treat diabetes, but now they're finding more and more health conditions that health plans need to provide coverage for these drugs. So most health plans cover GLP-1s, which cost $15,000 to $20,000 a year per person for diabetes, but they don't cover them for weight loss right now. Well, Wegovy was just approved by the FDA back in March for heart conditions. Sleep apnea is one that was just announced in April, that the same drugs might be approved now to help alleviate sleep apnea. More and more players are getting in the game. Viking Therapeutics is a startup that's working on their own GLP-1, which is more potent than the others that are in the market and may be seen as the best option out there, but it's going to be incredibly expensive. And now Medicare may have to start covering more of these GLP-1s because of the impact on heart disease. I'm not minimizing the value of these drugs and the impacts they have on improving people's health. There's certainly an argument to be made there, but they're very, very expensive, and there's more and more reasons that health plans are going to have to cover these. Just like if we have made a decision today that we're not going to cover them for weight loss, but we have to cover them for diabetes, and now we got to cover them for heart disease and sleep apnea. I'm waiting for male pattern baldness because that's something that I could use them for. Bottom line is pretty soon there's going to be a reason for these to be covered for everyone. And so the strategy we use to exclude them for weight loss today may not be effective a year from now. So we need to keep coming up with new ways to fight this fight. All right, last two slides. So low disruption things that you can do. Review your contract. Just make sure that, hey, we don't want to have massive changes, but we want to make sure that there's no truly offensive components of our contract. Stay apprised of what's going on in the industry so that if and when you feel like you might need to make a bigger change, it's not a huge homework assignment for you to figure out what's next. Understand what's coming from a gene therapy perspective. Understand how plans can deal with it. Make sure you're informed, and you may not want to pull any lever now, but when the time comes, you'll know what they are. And then stay attuned on what's happening in the insurance marketplace. It's evolving at a high rate of speed in terms of how insurance plans cover certain medications. Do they or don't they? Or are there new insurance products that cover a subset of these drugs, like gene therapy, for example? The answer is there are, and there may be available to you to consider. There's also more disruptive options that you can consider as well. Carving out your PBM if you feel like you need to, because it's not a two-way street. Exclude certain categories of drugs. We have clients that exclude those orphan drugs that I've talked about, or a broader classification of specialty medications. And there's no right or wrong answer there, and there's certainly consequences of doing so, but that may be a strategy you need to do. Or explore alternative sourcing solutions. How do we get these drugs more cheaply using other tricks up our sleeve, including international sourcing, which is a gray area. One thing that I just want to share with you real quickly, it's very eye-opening for folks when we talk about international sourcing. Many folks believe all these medications that we take are made here in the United States, but when we look at the top drugs that Medicare is paying for by dollars spent, only 32% of the drugs are actually made here in the United States. And that's true across the board for all health plans. Many of them are made in Europe, Australia, Africa, other countries as well. And so when we talk about importing drugs, maybe from Canada, for example, one concern is, well, hey, the drug's made here in the US and now we got to get it from Canada. Not necessarily true. It may be coming from Europe to begin with. Additionally, it is, when I talk about it being a gray area, and I'm going to go about 2 minutes over, and I apologize. When I call it a gray area, the federal government says it's illegal to import drugs from a foreign country. However, both the Trump administration and the Biden administration have said that they are not going to enforce that law because they understand the value of personal importation and allowing folks to do that. And the state of Florida just got FDA approval to start importing drugs from Canada for their state health plans that they manage. So is that a solution to this problem? Well, drugs cost about a third of what they cost in the United States when we get them from Canada. So certainly yes. However, at a broader level, it's still complicated from the United States federal government, and Canada is not very excited about it either because they have a limited supply. And if we start trying to import all their drugs here, the Canadian citizens are going to have a hard time accessing medications. So it's certainly something to consider, but it's not the end-all be-all. All right, final thoughts. Make sure that someone on your team understands what's in your contract and is staying apprised of what's happening, specifically with regards to prescription drugs. They are a double-edged sword. These new treatments that are coming out are life-changing or life-saving, and so they're incredibly important, and we want to make sure people have access to them. That said, it's pretty offensive about what some of these things cost, and we think there's quite the dollar grab that's being done throughout the pharmaceutical industry and the entire supply chain. And we think it's pretty offensive, and we want to make sure we're fighting back and we're not being taken advantage of. And then in closing, this could be the final straw. As these drugs continue to hit the market and increase in cost, there may become a point in time where insurance carriers, the federal and state governments say, we just can't do it anymore. And it'll be interesting to see what happens. I don't think that's in the next 5 or 6 years, but it could be in the next decade. So with that, I appreciate everybody sticking around for a couple extra minutes. Are there any questions that anyone has? No Q&A, so we'll wrap it up here and appreciate, so what is the difference between GLP-1 and gene therapy? So GLP-1 are the medications largely intended to suppress your appetite. So with regards to weight loss, getting diabetes under control, so those are your Wegovy's, your Ozempics, and so on. Gene therapies are more unique medications designed to treat a very small handful of folks, 20,000 people in the country, for example, that actually reconfigure the genetic makeup of the patient receiving those in an attempt to solve the broader problem. Things like sickle cell anemia and some very rare conditions. Sickle cell is one that just recently was approved last year. So gene therapies are very, very expensive. They're generally a one and done. At least that's the promise, is that they've solved the issue, whether it's what's the other one? Hemophilia, sickle cell anemia, and a number of others. Solves the problem. Take it, problem solved, and we're good. But the question is, are they actually as durable as they thought? And the answer is, we're not sure. But the gene therapy are more expensive than GLP-1, but way more people will take a GLP-1. Awesome. I appreciate you all being here today. Would love to dive into the conversation more with you individually when it makes sense. Have a great day.